Thank you for the introduction and for the invitation on presenting using epidemiologic research to establish public policy. To begin, I want to give a brief overview of what epidemiology is. Epidemiology is a study of patterns, causes, and effects of health in defined populations. And translational epidemiology is the effective transfer of new knowledge from epidemiology into the planning of programs and policies. Epidemiology can help shape policy and evidence-based practice by identifying risk factors for disease and for preventive health care. There are many different types of epidemiologic studies. Two of the most common types that are often used with omega-3 research as well as omega-3 policies are case control studies and cohort studies. Case control studies are retrospective, meaning that they're looking backwards in time. They select subjects based on exposure, so for example, selecting individuals who have cardiovascular disease, and then select matching controls. So for example, selecting individuals based on the same age, based on the same gender or body mass index. A strength of a case control study is that they tend to be faster and less expensive than cohort studies. However, they do have limitations. They can be prone to recall bias, so because they are retrospective, they ask patients or subjects to recall what happened in the past. As well, they can be prone to selection bias, so you're selecting people who already have that disease, who may be different from the general population. The other main type is a cohort study. These tend to be prospective, so they're looking forward, and they select subjects based on an exposure. Oftentimes, people are selected based on the absence of a disease, and then are followed until a disease or health outcome occurs. There are many different strengths of epidemiologic studies. One is that you can evaluate multiple effects of a single exposure. And by this, I mean that you can look at a single exposure like omega-3 intake and look at multiple different health outcomes. So for example, epidemiologic studies generally collect multiple different outcomes. So for instance, cancer, diabetes, as well as mortality outcomes. They can be more efficient for rare outcomes as well as exposures that have long latency periods. So the development of cardiovascular disease and cancer often occurs over a long period of time. Participants in epidemiologic studies tend to also be more representative of the general public than in RCTs or randomized controlled trials. So oftentimes RCTs have very strict inclusion criteria, and that results in people who have very different characteristics than the general population. As well, they can be more cost efficient versus RCTs on a per exposure basis. So both epidemiologic studies as well as RCTs are expensive. However, with observational studies, you can look at multiple different health outcomes. Compared to RCTs, which are really designed to look at a primary outcome and possibly a secondary or tertiary outcome. They can also be used for hypothesis-generating studies. So with RCTs, you really need a solid base of evidence to justify the need for an RCT as well as the safety of an RCT. Whereas with epidemiologic studies, if you think that there might be an association between an outcome and an exposure, it's possible to test this. So this is an example of testing an association. This is a study I led that was in a population cohort of about 1,500 older adults. Here we looked at a secondary analysis of plasma phospholipid fatty acids because we were interested to see if there was a relationship with fracture risk. So here we looked at greater polyunsaturated fatty acid, which were primarily omega-3 fatty acids, and found that there was an association with lower osteoporotic fracture risk, particularly in older adults. So this is a study that would have been difficult to do with an RCT because there is very little evidence in the literature. As well, an outcome like fracture risk takes a very long time to develop, so it would be very difficult to measure with an RCT. It is also important, however, to recognize the limitations of epidemiologic studies. One limitation is the timeliness of the data. So health and nutritional status can change quite rapidly, But by the time data from epidemiological studies is collected and analyzed, these recommendations may be out of date. So for example, the osteoporotic study that I just mentioned, the data was collected in 2007 and published in 2015. So the omega-3 intake may have changed quite dramatically in a population over the last 8 years. As well, epidemiology studies can be prone to bias, so recall bias, as well as patient selection bias, survivor bias, because individuals have to survive long enough to be included in health outcomes, as well as measurement bias. So because sample sizes tend to be quite large, oftentimes you're limited to self-reported intakes rather than biological or biochemical measures. And importantly, epidemiology cannot be used to infer causation. So epidemiology looks at associations, and this can potentially lead to spurious conclusions. Given the limitations of epidemiologic studies, why would we want to use epidemiologic studies? First is that they can help inform the design of randomized controlled trials, so they may be able to maximize the likelihood of success. You can look to epidemiologic studies to provide insight on what the dose needed might be, as well as the target population, so what is the sample size and characteristics of individuals that you want to target. Information on the effect size, which can help you determine the sample size as well, and the follow-up time needed that would be required to see your health outcome. This is an example of how epidemiologic studies may be able to overcome some of the limitations of an omega-3 RCT. This was a study that was a meta-analysis of RCTs of omega-3 fatty acids, and they concluded that there was insufficient evidence of a secondary preventive effect of omega-3 fatty acid supplements against cardiovascular disease. Now, this is really in contrast to the pretty consistent associations that have been found in observational studies. So then why is there this disconnect between observational studies and RCTs? Is it because the observational studies are leading to spurious conclusions so that there's only an association there and not causation? Or are there limitations in RCT trials that aren't inherent in observational studies? There are many potential reasons for the neutral RCTs. And I say neutral RCTs and not negative RCTs because most of the studies have shown equivocal effects of the placebo and the omega-3 and not a harm of omega-3s. So some of these potential reasons are cross-contamination of treatment arms. It's very difficult to disguise the taste as well as the odor of omega-3 fatty acids. So oftentimes people in the placebo group may start supplementing with omega-3s. It's possible that the treatment duration is too short. There's also debate about the use of an appropriate placebo. Oftentimes olive oil is used, which also has health benefits, including cardiovascular benefits. It's difficult to randomize people to consume or avoid foods that contain omega-3s. So asking people to avoid consuming value-added products like omega-3 eggs as well as fish can be difficult for extended periods of time. Omega-3 dosage may be too low and there may be too few subjects. Now, many of these areas can be overcome with epidemiologic studies. They're often very large, so you rarely run into problems with having too few subjects. As well, individuals really self-select their intake, so you're able to look at a dose effect, as well the cross-contamination issue and placebo issues are really non-existent then with epidemiologic studies. So the next area I would like to talk about is how epidemiology can be used to inform policy development. So what informs evidence-based policy? The important part is that defining the health needs and then using the best available evidence that can be chosen. And I say best available evidence because oftentimes policy is not rooted in evidence-based science. Policy is the combination of an immediate health need, ideally evidence, as well as political will. So the best evidence depends on the question being asked, and it's important not to delay action if there are immediate needs, as well as political will, and it's important not to delay action to wait for the best evidence to be generated. What informs the development of evidence-based policy? First, the health needs are identified so that the best available evidence that supports health needs can be chosen. The important part to emphasize here is that it's the best available evidence. The drive to institute policy is not always grounded in evidence. The need may be great and it may be immediate. It can also be the result of political will. And thus it's important to select the best available evidence rather than delay action to wait until evidence from RCTs can be generated. This figure depicts how the National Evidence Library rates the strength of evidence. At the top is a randomized controlled trial, and in the middle is observational studies. How can epidemiology inform policy development? It can help with research, surveillance, and monitoring, including identifying factors that can be favorably changed, looking at the level and type of benefits that can be achieved, the nature of promising interventions, and the resources required to implement this policy. It can also help with assessing programs and policies, so both at the pre-policy stage as well as afterwards. So it can be important for helping to understand the disease and the population to be targeted, as well as evaluating the effectiveness of the policy and program, as well as the safety of the policy. There are, of course, challenges in using epidemiologic data. The main one is that the impact of policy on health cannot be unequivocally traceable to that policy or intervention alone, because epidemiologic evidence cannot be used to infer causation. It's also possible that there are unintended consequences. So there could be an impact on other health parameters. In epidemiologic work, we do control for confounders that also have an effect on the health outcome. However, that control is not as rigorous as in an RCT trial. So the key in using epidemiologic research to set policy is really to manage risk as well as expectations. And ideally, evidence-based policy should rely on a broad and diverse base of evidence from different study designs that complement each other. And then finally, I want to give some examples of how epidemiology has helped advance omega-3 policy. One of these comes from the 2015 dietary guidelines, which were recently released. And they recommend the consumption of seafood, including seafood choices that are particularly high in omega-3 fatty acids. And much of this evidence was pulled from strong prospective epidemiologic studies. Looking at opportunities to inform future policy, one of these areas where epidemiologic research could potentially help is with defining an omega-3 DRI. So in 2002, the Institute of Medicine concluded that an EIR for omega-3s could not be established due to lack of data on requirement for healthy individuals for adequate growth and neural development. However, since then, there's been a wealth of new data that supports the need to revisit this recommendation. So this is nicely summarized in this paper here I have referenced at the bottom, and it includes the use of about 24 epidemiologic studies to support this. As well, to demonstrate the need for an omega-3 DRI, it's important to look at the population level intake of omega-3s, the status as well. So trying to show that there is a need for an omega-3 DRI. This is work that I led in combination with investigators at Cornell and DSM Nutrition. And we used data from the National Health and Nutrition Examination Survey, which is a large epidemiologic data set in the United States. Here we looked at plasma levels of omega-3 fatty acids, so looking at the status of individuals. On the y-axis is the plasma N3 PUFAs, which is EPA, DHA, and DPA, relative to total fatty acids. And on the x-axis is the percentile. So the dashed line represents the level associated with 2 servings of seafood per week, which is the dietary guidelines. And the solid line represents the level that is associated with cardioprotection. So you can see that over 75% of individuals have levels below that recommended by the dietary guidelines. And over 95% of individuals have levels that are below that associated with cardioprotection. So thus, this epidemiologic data really shows the need for intake that needs to be increased in the United States and provides impetus for revisiting the N3 DRI. So what can we do as researchers to help advance omega-3 work into policy? The first is to conduct high-quality, well-designed studies. Consulting the Nutrition Evidence Library rating system is helpful to ensure that you can maximize the likelihood of the evidence that you generate being used to inform policy. It's also important to advocate for standards in reporting and analysis as researchers, as journal reviewers, as journal editors. So this importantly will help minimize some of the heterogeneity that limits the importance and applicability of epidemiologic studies. And this is also relevant for other types of study designs as well. And finally, to collaborate across research methodologies. So epidemiologic research is really strongest when combined with other complementary areas, so things like RCTs as well as experimental or basic science. And what can you do as industry members? One of the main areas is really supporting epidemiologic research. I was really encouraged by the invitation to present today because it shows me the industry is beginning to recognize the importance of alternative study designs and how they can help inform omega-3 policy. As well, partnerships with researchers and industry are important, particularly since researchers, and myself included, tend not to be terribly strong in the areas of advocacy and amplification of evidence. So oftentimes, decision makers and policymakers don't have a background in scientific evidence, and it's important to communicate to them clearly the importance of epidemiologic research. So to summarize, well-designed epidemiologic studies can help advance omega-3 research and inform public policy. And action should not be delayed until evidence from clinical trials is available if present knowledge from epidemiologic studies illustrates a consistent need for actions to benefit health. Thank you.